presenting for Nursing 601 Pharmacology a case study on Janelle, who's a 35-year-old woman with depression. She's been on fluoxetine 40 milligrams for about a year. She feels a little better, but thinks she's not as happy as she should be. She does see a counselor, but reports it only helps a little, and is wondering if there's something else we can do about her medication. So a brief rundown on the depressive disorders. They are characterized in the DSM-5 not too significantly differently than the DSM-4, and I'll get into some differential diagnoses for Janelle later on. But this infographic is a good example of how depression is often misunderstood by the public, just that there's lots of conflicting ideas of symptoms that may present that don't always align with clinical definitions of depression. One thing that's slightly different in Western medicine is that we don't always consider somatic symptoms as a primary complaint, which is the case with many people across the world experiencing depression. Risk factors include being a female. The prevalence is higher than in males. Childhood trauma, a genetic predisposition. It is about 40% heritable. Chronic or disabling medical conditions and substance use disorders or certain medications can also trigger depressive episodes. Pathophysiology is still fairly poorly understood. We understand that likely serotonin and norepinephrine contribute as well as dopamine, but that continues to develop. So what are the pharmacological treatments for depression? The most popular medication today used for depression are SSRIs, which Janelle is on. Prozac is one of the SSRIs. There's also SNRIs, atypical antidepressants, and tricyclics. MAOIs used to be used more often, but are very rarely used today because they have quite a lot of side effects and conflict with many foods, so they can be dangerous. SSRIs work by raising serotonin levels in postsynaptic serotonin receptors. This happens almost immediately, that effect on serotonin, when a patient takes the SSRI as soon as it's metabolized. But there are downstream effects that affect lots of neuroprotective proteins, which take quite a while to manifest. So it's important to educate patients that these effects can take weeks and weeks to fully manifest. So they should be on a trial of an SSRI for at least 2 to 3 months before ending the trial. The half-life of SSRIs is about a day on average. It does vary from one SSRI to another, but that's good to know that missing a dose does not mean that there necessarily won't be any in the patient's system. They do weakly inhibit cytochrome P450, so it's important to be sure that a patient isn't on any drugs that may conflict. SNRIs have a similar effect to SSRIs. They also affect serotonin, but they do affect norepinephrine as well. And some SNRIs affect serotonin more than norepinephrine or vice versa. And this effect can also vary quite a bit depending on the dose of the SNRI, so that's important to understand. They're very slightly more effective than SSRIs, statistically significantly, but on the very low end of statistical significance. And they do have more side effects, so that's likely why they're not used as much. Atypical antidepressants can be quite successful. Bupropion or Wellbutrin is also used for smoking cessation. Mirtazapine or Remeron can be used for insomnia. And these can be second line to SSRIs if they're ineffective or if an SSRI is causing some undesirable side effects. A common side effect is sexual side effects with SSRIs, difficulty to or extended time period to orgasm. Tricyclics increase norepinephrine. They have some anticholinergic side effects. And as we've discussed in class, tricyclics are easier to overdose on compared to other psychiatric medications. Prozac's almost impossible to overdose on. So that's one reason they're rarely used anymore, is that many depressed patients are suicidal as well. And threw in a picture of Prozac in the bottom corner there. So some history gathering with Janelle. First off, when was she diagnosed with depression? Is Prozac the only medication that she's been on for depression? Has she tried another SSRI? Have any family members of hers been on SSRIs in the past? And if so, what was effective for them, or another class of medication that was effective for them, because she may have a genetic predisposition for a certain medication? How do her symptoms present? Is she having difficulty completing ADLs and having some neurovegetative symptoms like that? Are they affecting her work or social life? Does she also experience any anxiety or restlessness, and how does that affect her life? Also, do her symptoms seem to follow a seasonal pattern? Have they followed hormonal changes in the past related to contraception she's taken, or menstruation? The DSM-5 does actually characterize premenstrual dysphoric disorder now, in that depressive episodes can align with, depressive episodes can align with ovulation and then resolve shortly after menses. Did she have a significant stressor in the recent past? Does she ever experience high irritability, need for less sleep, high sexuality, extreme talkativeness? This would just rule out hypomanic symptoms and be sure that she hasn't been misdiagnosed with depression and maybe has some bipolar symptoms. Has she ever had her thyroid tested, and what's her family history? Does she have any medical disorders like MS in her family history, or hypothyroidism that could contribute to depression? And then just some more questions about sleep, diet, finances. What are her relationships like? And then, does she have any guns in the home? Does she think about suicide? If so, what are some safety plans she has? And does she have a plan or intent for how she would suicide? Is this a highly successful method, like via gun, things along those lines? And that's a discussion that hopefully she's open to talking about with loved ones as well, so that they understand a safety plan for her. So here are Janelle's symptoms and history after we've met with her. Subjectively, she's feeling pretty tired physically and mentally. She reports enjoying sex less, reports sleeping quite a lot and not always feeling rested, reports feeling depressed about every other day, part of the day, denies any appetite change or anxiety, poor concentration, denies SI, denies any recent stressors, and has a pretty moderate to low alcohol consumption. Says that she splits, a bottle of wine with her girlfriend once or twice a week. And then objectively, when she comes into the office, she has a very expressive affect. She's well groomed, appears her stated age, her vitals are normal, her thyroid testing's normal, and she doesn't have any recent weight change and doesn't have any comorbidities that should conflict with any pharmacological intervention. Then a history of Janelle. She did start Prozac about a year ago, as reported, doesn't have great compatibility with her therapist, doesn't take any contraceptives, and is excited talking to her girlfriend about adopting or fostering a child. Does report that she has some genetic predisposition for depression because her mom was always down when she was a kid, and her mother also attempted suicide once via overdose. So a differential diagnosis for Janelle. Most likely she doesn't qualify for any of these listed diagnoses. The top four I have here: major depressive disorder, adjustment disorder, mood disorder due to other medical condition, or substance or medication-induced depressive disorder. She does have some of the symptoms listed under major depressive disorder, but absolutely not 5 or more. Adjustment disorder, she hasn't had any recent stressors that would contribute to that. She doesn't have any medical conditions that would contribute to her mood disorder. And her alcohol consumption, as I said, is pretty moderate, so it doesn't seem like she has a substance or medication-induced depressive disorder. She's not on any other medications. And then just at the bottom, I listed sadness. It sounds like her depression is subclinical, so normalizing with her that it's normal to feel down at times, and investigating a little more the timing of her depression and if it feels like it's related to seasonal change. As I said, Janelle doesn't seem to meet any of these criteria, so leading diagnosis for her is unspecified depressive disorder. This is a disorder listed in the DSM-5. It's often used for patients inpatient or in the emergency room where it's difficult to quickly find an etiology for their depression, and when you're somewhat uncertain about the severity of their depression. So this might develop as a provider has a longer relationship with Janelle. But it seems like since her depression hasn't been going on for 2+ years, it's not dysthymia, and the severity doesn't make it seem like it's major depressive disorder. So unspecified depressive disorder is the same symptoms of major depressive disorder, but just not as many and not the same severity. So how are we treating Janelle's depression? Pharmacologically, it seems like the serotonergic effects of Prozac don't seem to be helping her. I think bupropion, seems like a good option because it has dopaminergic effects rather than serotonergic. And I think this could potentially reverse the sexual side effects she's having from the SSRI. And because Wellbutrin can be a little activating, it could potentially also address her hypersomnia. So changing between these two would necessitate a cross taper. Very important piece of education for Janelle would be telling her about the SSRI discontinuation symptoms. These can be very unpleasant for some patients. She's on a lower to moderate dose of Prozac, so hopefully she won't experience too many, but these can include dizziness, feeling a little out of it, headache, nausea, and brain zaps, a feeling of mild electrocution. So definitely important to educate her on that so that she can normalize those symptoms when she may experience them. And these definitely could occur because she's not switching to another SSRI, she's switching to a dopamine affecting antidepressant. I'll talk a little more about the side effects of Wellbutrin later on. And then in addition to pharmacology, she also needs to address her psychotherapy. Sounds like she's not enjoying her relationship with her therapist. So what types of therapy appeal to Janelle? There is strong evidence for CBT, for depression and anxiety and other psychiatric disorders. Potentially she could look for a therapist that has some experience in CBT. Maybe she'd also be interested in group therapy or maybe couples therapy if she'd like some support from her partner. And then behavior change. Does she think that her habits are working for her right now? Does she get enough sleep? It sounds like she sleeps too much. Is there any way she can modify that on her own with some of her sleep habits? Does she exercise much? What's her diet like? Potentially integrating some things that would facilitate mind-body connection like yoga. So some education on Wellbutrin, very important. Janelle shouldn't rapidly increase or decrease her alcohol consumption because this can cause seizures. Janelle and her partner should be aware that starting a new antidepressant can increase suicidal ideation. So monitoring her affect and her mental status and making sure that her partner is on board with that. And again, securing any guns they may have in the home if they do. Practically, she can swallow Wellbutrin pills whole and she shouldn't split them. And she can take it regardless of meal timing, so it shouldn't give her stomach upset, and it also will be absorbed fine regardless of meals. And educating her on the activating symptoms of Wellbutrin, so it could cause tachycardia, some restlessness. Hopefully this helps with her hypersomnia, actually. That would be one of the goals. And may cause some dry mouth. She could try chewing some sugarless gum or using cough drops. And then again, emphasizing that no medication is a panacea. It sounds like Prozac has been mildly effective for her, so she could benefit from another medication, but she also needs to work on changing other aspects of her life to hopefully facilitate good mental health. So what are Janelle's desired outcomes? She wants to sleep less, suffer less from the hypersomnia, and also feel rested. She wants to have a better enjoyment of sex with her partner, wants to have an improved mood, have more energy in general, and then find both a therapist and a type of therapy that she enjoys. So hopefully this plan can facilitate those. And then as a provider, need to monitor blood pressure. Wellbutrin can cause hypertension, so that's important to check. Body weight fluctuations. Wellbutrin can cause both body weight gain and loss. And if she's having any vegetative symptoms, she may be gaining more weight, so monitoring that as well. Keeping an eye on her mental status. Any sudden changes could indicate suicidal ideation, so making sure you're informing her partner of that, or Janelle is, and that during her checkups with you, you're also keeping an eye on her mental status, and then monitoring renal and hepatic function as well, because Wellbutrin can have effects on both of those systems.